Spinal Truth Show weekly podcast edition. I'm your host, Dr. Caleb Slater, joined here by my wife, orthopedic and pelvic floor guru, Danielle Slater.
It's an honor to be back again. Thank you for having me.
Do you like guru?
Yeah, love that.
So this week we're talking about Thoracic Outlet Syndrome, and it's another one of those conditions that I think is very poorly managed throughout the entirety of the medical field. Specifically our aspect of the medical field, physical therapy, and then ultimately the surgery that poor management leads to is kind of horrific. So let's talk about what thoracic outlet syndrome is. It's compression of the nerves, arteries, or veins as they leave your neck, pretty much the bottom of the neck here, and travel through this area right behind your clavicle and in between your first rib. And your first rib, for most people that don't know, is actually pretty high up. It's above your clavicle. So it can get compressed in this area either by the first rib, by the clavicle, or by some of the musculature. Typically, it's the scalenes on the sides of your neck, the anterior middle scalene. These nerves, arteries, or veins get compressed, you get pain, numbness, tingling, weakness running down your arm. You might also see color changes, temperature changes in your arm. You'll get diagnosed with thoracic outlet syndrome, and then you get sent for treatment. And the treatment is where I get kind of upset. And to be fair to a lot of the people out there doing these treatments, the reason I know they don't work is because I've done them in my career. And when I just kept not seeing the results that I wanted to see, I kept trying to find something different. But I was still doing pretty much these treatments until I found something different. And for primarily the main treatments are stretching the musculature and postural re-education, as well as nerve glides. For stretching the musculature, it's mainly stretching the scalene. So you'll have people do this stretch. You'll either have them sit on their arm or their hand and depress their shoulder. You're trying to stretch the muscles on the sides of the neck. You're trying to stretch the pec and pec minor, so down here, which is kind of annoying because if it's true thoracic outlet syndrome, then it's not compression at the pec minor, coracoid area. The reason this doesn't work is that typically these muscles are already tight, fibrotic, and the way to get them actually more elastic, the way to get them more pliable, the way to restore the tissue is actually through contraction of the muscle. So stretching, even if it makes you feel good in the moment, which it often doesn't, it's just passive and doesn't last. It doesn't create any type of change. Same thing with the pec musculature. You can stretch that all day long, and maybe it helps, but as soon as you go back to sitting, driving, computer work, reading, you're right back to that same position that you were just trying to stretch out of. So the better way is to contract these muscles. The better way is to contract the muscles opposite the pec in order to keep your body in that position. Additionally, they do a lot of nerve gliding, and I'm not a big fan of nerve gliding. I find that it's more irritating for the most part than it is relieving.
Yeah, how would you say that your approach to movement is different than nerve gliding?
So the first thing that I do is I work on the spine, and so in preparation for this, I looked up some exercises and treatments that are typical online. So I did some YouTube, and the main one that I do, at least at first, is thoracic extension. And the reason that is that, so everybody talks about postural re-education, but your thoracic spine, if it's stuck forward, nothing you do at the neck, nothing you do at the chest, like at the pec musculature, is going to have any effect. So you need to get your thoracic spine into extension. That affects your neck, that affects your shoulders, that affects that thoracic outlet area. I saw the first video I pulled up, it's some guy using a foam roller, and I'm like, oh, great, like this guy's doing what, and then he's just rolling along on the foam roller, like doing like a trigger point release. You ever see the people at the gym just like roll back and forth? That does absolutely nothing, and I'm like, damn it.
I know, I always tell people a foam roller is my favorite piece of equipment, exercise equipment in our house, but I don't foam roll any muscles or trigger points.
Right. And again, you used to, right? I know you used to do the IT band one. Remember that one? Yeah, used to do that one. I don't know if I ever rolled my back up and down the foam roller.
My quads, my hamstrings would be like, oh, that's so sore. But I don't think it ever helped any symptoms that I was trying to use it for.
No, and at least not long term too. Like, I don't want to say that there's not value to stretching. I don't want to say that there's not value to massage and trigger point release and grass and all this other stuff, right? Which is done for thoracic outlet syndrome. So they'll massage the scalenes, they'll massage the pec, they'll do trigger point releases to the pec and the scalenes, they'll mobilize the first rib. All this stuff has value, but what has more value is creating range of motion movement at the spine at first, and then strengthening in that area to keep your spine in that position. Then hopefully that took some pressure off the nerve. Now that you have pressure off the nerve, this still isn't where I would go next, but now that you have pressure off the nerve, now if you do nerve gliding, nerve flossing, where you're trying to mobilize the nerve, pull it back and forth, now that you've taken pressure off, you'll be more successful and it'll be less irritating. So instead of just trying to yank that nerve back and forth from out from underneath the compression that's on it, take the pressure off, then you can move the nerve if you need to, which you often don't.
Yeah, and it's so easy to anger a nerve.
And
I can remember early on giving nerve glides. It's like a classic thing I feel like we learned in therapy school, positions how to tension a nerve and thinking, oh, the nerve is bound up, so let's try to mobilize it. But so often those patients came back feeling so much worse.
So much worse. And once you excite the nerve, it doesn't calm down quickly.
No.
So it's quick to excite, quick to piss off, and it takes a long time to cool down. And again, I've done this in my career. I've done so much nerve gliding in my career, and I've done different types. I've done the ones that you learned in school. I did the ones that I learned through like Maitland, which I like them better, but it's still like what you found. It's still, most of the time, it's just irritating the symptoms, irritating the nerve.
Can you recall when you were preparing for your like OCS certification, when they would talk about and highlight thoracic outlet best practice and treatment, them saying you need to begin at the spine, you need to start
absolutely not. No, they actually really do the typical approach. And the typical approach is that postural re-education, stretch the scalenes, stretch the sternocleidomastoid.
Is that
Chris, you love that sternocleidomastoid?
Well, first off, as a nobody, postural re-education sounds very aggressive. I don't know what that is.
You want me to show you?
Well, and
there
this
you go.
is funny.
I just re-educated my posture.
All right.
There you go.
Chris says a nobody, but there's any technical question, computer question that I have, and he has the answer in a second.
Well, you guys have been talking about thoracic outlet syndrome. I thought that was the name of the new Jurassic Park movie or something. But like, what is like, dumb it down, what is thoracic outlet syndrome to most people who aren't diagnosed with it?
Most of the time it's pressure on a nerve coming out of your spine. So it goes brain, brainstem, spinal cord, and then little tentacles come out of the spine, and they go everywhere in your body to give your body information, to give your muscles, your joints, your tendons, to your skin information, so it can perceive pain and movement and stuff like that, right? Most of the time, you'll see people that they'll say, I have NTOS. It's neurogenic thoracic outlet syndrome. So it's pressure on the nerve. So pressure on that nerve, and now wherever that nerve goes, you'll get pain, numbness, tingling, or weakness, and maybe even like skin changes and temperature changes and sensitivity changes and stuff like that.
If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you, and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
So does it always happen in your neck?
Well, that's where the thoracic outlet area is. It's an area right here.
So if you have a nerve pinch somewhere else, is it the same thing but just at a different part of your body?
It'll get classified as the same thing, but it's just compression on the nerve further down. So
Like
it's not
sciatica.
Yeah, like sciatica. All right, sciatica is a catch-all term. It's like saying fish. There's a bunch of different types of fish. Sciatica is the irritation of the sciatic nerve. The sciatic nerve can be irritated right when it emerges from the spine. So at that like little hole, the foramen where it comes out. And at that area, it can be compressed by a bunch of different reasons. A disc could push on it, the facet could push on it, the ligament could push on it, a bone spur could push on it. But then as that nerve travels down, it can get entrapped between muscle and fascia. So there's other points, common points that can put pressure on the nerve. Any pressure or irritation of that nerve along any of its pathway is sciatica, okay? Kind of the same thing here. These nerves travel. Any pressure on those nerves causes almost the same symptoms, but it wouldn't be true thoracic outlet syndrome. It would just be compression on the peripheral nerve.
Do you remember a couple years ago when I had symptoms of compression to some part of that nerve pathway?
Yeah, what brought that on?
Yeah, pretty stupidly, I signed up for like this New Year's workout, and I went in without doing any training, and it was a countdown for the new year where you did that year, so it was 2023, that many burpees, that many sit-ups, and then you count down, then you do 22 of them, 22, 21. So at the end, you're our math guy.
I mean, there's a formula for it.
I think it was close to like 270 by the end, and you were doing them as quick as you can, and I'm like, I got this, I can do it. And actually throughout the workout, even though I was dying, I was still okay, right? Got done. That night, started to feel like a little uncomfortable in my neck. Couldn't really get in a great position. But I feel like the next day I was at work and wasn't able to stay at work. My arm kept getting like this searing pain going all the way down from my shoulder down to the point where then I couldn't even move my arm. It was kind of a scary experience. Fortunately, within a few days of, luckily I'm married to a PT who can help me treat it and guide it and
So what did I have you do?
Actually, thoracic extension was like the only position lying down I could get in that I could get complete relief from my symptoms. But as soon as I would like move and get up, I was like in agony.
Did I have you do any scalene stretching?
No.
Or trigger point release, massage?
No.
Did I have you stretch your pec?
Nope.
No.
It probably would have put me through the roof.
Maybe. Any nerve gliding?
No.
Yeah.
And I mean, that was extremely acute, treated it immediately. I knew a triggering cause. It wasn't like a cause that's building up maybe for some people who are working in poor ergonomics and it's like trickling on over years and then it manifests very chronically. So I'm very fortunate that within a short time frame, like days to weeks, I was 100% better.
Well, and then you got the right treatment right away. And so like your symptoms, like what you said, didn't become chronic.
Yes. Because I feel like so often with that, if I had no experience in the field at all, I probably would have been at the ER.
Sure.
Right? I'm a little bit worried about
a stroke,
symptoms,
right?
and I can't do any. It was hard to figure out how to make them feel better. And what would they do there? They would give me pain medication, but probably would have a hard time guiding me how to get rid of the symptoms.
I don't remember this answer, so I'm literally asking. I'm assuming I pressed on your spine.
You did.
Where was it tender?
I mean, this is going back 2 years ago, so I have to rack my brain a little bit. But I believe it was lower cervical and maybe upper thoracic.
Which makes sense. Yeah. And I would think that's the case for most people. And this is where I typically start for these type of symptoms. And again, it's just getting that area extended. You open up this space, you take pressure off the nerves, you restore normal joint alignment, and when people say postural reeducation, honestly, it makes me so upset. It's boring, and I hate everything that most people do for it. Mobilizing the spine in that direction and then strengthen in that range. It's not that hard. We've overcomplicated it, and we do a whole bunch of stuff that's just not effective. And you do that corner stretch in the doorway, and you do the pec stretch on the foam roller, and you do like trigger point releasing and massage, and you put a tennis ball here and you lay on it, and all this muscle release and stretching, it just doesn't have lasting effect. So you do all this effort, you go through some pain, you go through the stretching, you do this like multiple times a day for weeks, and at the end of it, you're pretty much left with as soon as you stop doing it, you're going to go right back to where you were because you didn't actually gain any range of motion, any spinal range of motion, and you didn't gain any strength in that range to keep you there.
Yeah, I can definitely attest that I can't imagine someone going through those symptoms and having it for a prolonged period.
It can be awful, right?
Yeah.
And that's why there's a lot of people out there like, I needed the surgery, right? And let's talk about the surgery. So the surgery is typically they remove the first rib and parts of the two scalenes. So they'll do a scalenectomy. So they remove two muscles, parts of two muscles, so your anterior and middle scalene, and they resect the first rib. Every once in a while, they also resect part of your clavicle. So they take away 1 to 2 bones and
you didn't need them,
2
right?
muscles to decompress the nerve. And then you're back to physical therapy for weeks to months. And I want to kind of pose a question out there. If you've had thoracic outlet syndrome and you've had the surgery, was it successful? Because if you look up online, you'll see like 80 to 90% success rate. I have not seen that clinically. Clinically, I've seen people where maybe they had temporary relief, but then their symptoms came back. And for the most part, and I've also seen people who've had surgery and their symptoms just got jacked up from there. It just stirred up. So I don't know. Have you seen relief from that surgery clinically?
Yeah, that's a great question. And through the past patients I can think of, no. We do get a little bit of patient bias because if people had the surgery and felt fantastic, they're probably not coming to PT.
Possibly.
So we account for that, but no. I don't know of like anyone who's told me a great success story where.
If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
It also doesn't sound right though, too, right? Why all of a sudden does your body not have enough space to account for your nerves that it used to? And now we need to take away 2 muscles and 1 to 2 bones.
What kind of limitations would that leave you with then?
I mean, the clavicle is probably the worst one. I mean, obviously they take away muscles, it's decreased strength. Those muscles are accessory respiratory muscles as well, but I mean, they're taking away the rib that it attaches to. So like they help you breathe a little bit. So
Pretty important.
yeah, they're accessory and they're small, and again, they're taking away they help you breathe by elevating the rib cage, but they're taking away where they attach on the rib cage.
I mean, the body is pretty miraculous and can usually compensate.
The clavicle is the big one because that's your strut to your shoulder, so now your shoulder is much less stable, or your shoulder girdle. Either way, I don't want it.
No.
Yeah, and at the end of the day, I think it's preventable, and I think it's preventable if you get the right treatment early on, and the right treatment, and I'll come out with some videos for the exercises that I typically recommend for this, and it's thoracic extension over the foam roller, and then some type of muscle contraction in that range, and then getting the muscles on the sides of the neck to contract. And
So simple.
it's simple, right? And then if you need to, like, I'm not saying that like pec stretching and nerve gliding doesn't have value, but you need to set it up for success. And if I just stretch my chest and I do nothing to mobilize my spine in that direction, and I do nothing to strengthen the muscles back there to keep me in this position, I'm gonna lose it. So I'm gonna spend all this time and effort stretching, and I'm just gonna lose it on the drive home. I'm going to lose it sitting at my computer or messing around on my phone in my bed.
Well, it's like the whole world right now, right?
The whole world,
all
right.
on technology. We're all flexed all day long.
Right. And that's why, honestly, the thoracic extension over the foam roller, I do that for so many types of patients, so many pathologies, headaches, dizziness, neck pain, shoulder pain, any type of arm pain, chest pain, breathing issues, people that get wrongly diagnosed with asthma and acid reflux, and a lot of that area.
Well, that thoracic area really has a lot of connection.
Has a lot of connections. Yeah. I mean, it's a large area, 12 bones, right? And it houses your sympathetic nervous system, so it has control over your fight or flight. It has control over your respiration, your heart rate, your blood pressure, your thermal regulation. And then it's the basis on what your neck sits on. So, and that's kind of the point here, is that if you want to treat the neck, a lot of times the best treatment is first the thoracic spine, because it's kind of like building a house. Like if you have a bad foundation, there's no point in putting up walls. And same thing, like if I have a bad thoracic spine that's tipped forward, whatever I do at my neck, it's going to be less successful because it's my thoracic spine that's pitching my neck forward so much. So
Makes sense.
First work on the foundation, and then you're set up for more success later on.
So I have a couple questions.
Go ahead. Fire away, Chris.
So how do I get diagnosed with thoracic outlet syndrome? And then if I'm diagnosed with it, who should I see to get proper treatment? A chiropractor, a physical therapist, a doctor, a surgeon?
I'm not a surgeon, so I can rule that one out.
Okay.
And to Danielle's point, if you have it and you have some form of nerve compression, nerves suck. Nerves put you in a lot of pain. And then arterial and venous also can cause a lot of pain, and they can become more severe. So if it's an artery or a vein that's compressed, there's typically more signs if it's an artery or vein of coldness in the hand, arm, temperature, or color changes, stuff like that. There's different ways for those. There's the term's escaping me right now, but there's a test for the arteries and veins that is pretty accurate to show whether or not they're compressed. For the nerves, now it gets more muddled. There's tests that we do as physical therapists. It's called an Adson's or Ruse or military test that you can do. It just puts your arm in certain positions, and it sees if you lose your pulse or if you reproduce symptoms. Those tests kind of suck, though. Then you can get an MRI or a CT scan, and this is looking for bony abnormalities like maybe an extra rib or compression on the nerve. However, these tests are so much more inaccurate and misleading than most people realize, and I say this all the time. Remember, they're taking these images in a position of comfort and laying down, and that might not be the position you get your symptoms in. Also, too, they can show like changes in bone or structure, but those changes that are often there over time, over the course of our life just normally, don't necessarily mean that you are getting symptoms from them. You could do a nerve conduction velocity test, but these are kind of like the sensitivity is relatively poor of them. And you could do an ultrasound, and that'd be more for like venous or arterial. Those are the main ways, right? The way I like to diagnose, because all of these tests have their limitations. Obviously, if there's something life-threatening, you need to rule that out first. And that's what these tests are pretty good for. Specifically like an MRI or CT scan or something like that.
No
ruling
tumors
out a
there,
tumor, space
pressing.
occupying lesion, stuff like that. If there's, signs of, like we're talking about pain running down the arm, you want to rule out heart attack, you want to rule out stroke, you want to rule out space occupying lesion, like a tumor, stuff like that. Once that's been ruled out, the way I like to diagnose is relatively simple. Listen to the patient's symptoms, when they started, where they are, how they behave with movement and activity, what they've done for them, and how they've responded to that. If they rest, if they ice, if they stretch, if they went to PT or chiropractor, or they took medication, how did that do for your symptoms? Because if it's an inflammatory issue and you took anti-inflammatories, your symptoms should respond pretty well.
Yeah,
right?
I feel like a great history gives me more information than all the imaging and documents a patient can bring to a visit.
And it's so boring to say that, I feel, but it really is. Like I start by listening to the history of your symptoms. Then I look at your movement and I see where you're limited, and I have an idea of where in your body it's coming from, and we see how your symptoms respond with movement. If you turn your head, does your symptoms get better or worse? And we try to map out your symptoms. We try to reproduce your symptoms in the clinic. So if you're having pain running down your arm, I'm trying to find positions or movements that reproduce that. And then the next part is the part where I really diverge from the rest of my field. And that's where I look at your spine and the area of your spine that could be causing these symptoms. And I see by either you moving or me putting pressure on those individual levels, if we're able to reproduce and or alleviate your symptoms. So basically change your symptoms. And right then and there, I try to find something that you can do or I can do to alleviate your symptoms, and then we retest. And if they've changed, if they're better, obviously we're doing the right thing. If they're worse, then we still know that we're working in an area that is attributing to your symptoms. We might just need to do it a little bit differently. And that's the way I like to diagnose. So I almost like to diagnose through treatment versus through tests. And I feel like that gives me such a better picture of this patient and how they respond and how they move and how they respond to treatment in a specific area. And that's the treatment that I want the medical field, specifically physical therapists and chiropractors, to adopt. I want them to first listen to the symptoms, and everybody does this. They're going to say everybody does this. And I want them to map out the symptoms and the movement, and they're going to say everybody does this. They don't do it, maybe as well, right? Or as detailed. And again, I do an hour for an appointment. I do an hour, so this is all done, and then the patient education and taking them through exercise is what takes me the longest. So like, this is all done. This takes about 30 minutes. About 30 minutes to get the history, evaluate their movement, reproduce their symptoms, figure out where in the spine it could be causing, treat that area, show them to treat it, and then retest and see if it's changed. It takes about 30 minutes. So I want the system to adopt this because it's the most effective form of evaluating treatment and evaluation and treatment that I've found in my 17-year career. And I think it's very logical as well. You're ruling out the involvement of the spine first. You're starting there. You're taking pressure off the nerve. You're restoring spinal movement. And then you're seeing if it affects their symptoms that they're coming in for, their wrist pain, their knee pain, their arm pain, whatever. And it so often is the case, it's annoying.
Yeah, it's just mind-blowing that it's not the first treatment given for almost any condition.
No, almost never.
So it can affect pretty much, anyone can pretty much get thoracic outlet or be diagnosed with it who has even an athlete or an office worker because of. Yeah,
and they're both being sedentary and being active causes thoracic outlet syndrome. And it's basically anybody that's having pain, numbness, tingling running down their arm, it's possible that you have thoracic outlet syndrome. And now they'll take you through certain tests to see if it's that versus a cervical radiculopathy, which is basically pressure on the nerve at the nerve root, so a little higher up. And I'll tell you, it's really, really hard to discern the difference. And that's why treatment is kind of one of the best ways to diagnose. Because if you're treating at that nerve root area and it's improving, great. If it's not improving, maybe give it a little bit more time, maybe try a little bit different of an approach. And then if it's not improving, all right, now you can kind of move further down. Now you can move to the more, more normal treatment.
And if you aren't diagnosed, but you have some of those symptoms, is there something you could do at home to kind of either treat or kind of diagnose yourself?
I wouldn't say to diagnose yourself. I think that's hard. Yeah. And I also think the first thing that we do is run by all of your symptoms, and part of that is because we are trying to listen for red flags. We're trying to listen for things that could be very dangerous. Signs of a stroke, signs of a heart attack, signs of a tumor, signs of an underlying fracture, instability or something like that. And we're going over your history. Do you have a history of rheumatoid arthritis that leads to more instability of the spine? Little stuff like that you don't know. And so giving that to somebody else and having somebody else tease that out first, make sure that you are safe in applying this. After that's done, and that would be ideal. After that though, then honestly, there's probably 3 simple movements that I would do for 3 to 4 simple movements that I would do for thoracic outlet syndrome type symptoms. And again, one of them, it's extend the thoracic spine. Then do a movement to kind of contract the muscles in that range. And then it would be contract the muscles on the sides of the neck. And in doing so, you're moving the ribs around, you're moving some of the tissue around in that area. There you go.
And I feel like you commented about having someone like take you through an evaluation versus self-diagnosing. And even as PTs, I feel like if we have something wrong, I'd rather go to someone who can be completely objective about it, because you're going to have your own biases. And even going to a family member isn't always the best.
It's never the best.
No.
Wait, and me and you have a bunch of stories of both of those, right? Of getting our own symptoms wrong. Me, I thought I had a calf strain and it was my back, right?
Yeah.
And because when you're a patient, even if you have, it's kind of like the saying, like saying in law, that person who represents himself is represented by a fool. It's kind of the same thing with doctors and PTs and stuff like that. Like you're not a objective clinician. You are a person in pain, and you are fearful and worried and responsive instead of, and reactive, instead of clinical and logical and objective.
Yes.
So, and it's the same thing when a family member comes to you, and you almost always skip steps when they come to you. You don't go through the whole process. You're like, all right, fine, lay down, I'll push on you, or move this area or whatever, and you don't set your baselines, you don't go through the history. The verbiage that you use for them is shorter or sharper, and their response to you is the same. So it's best to go to somebody that knows what they're doing. But that person should be able to give you relief in a very short period of time. We're talking somewhere around 50% improvement within about 4 weeks for most symptoms, and thoracic outlet syndrome being one of them. And if you're not getting that, you're probably getting the wrong treatment.
And the hard part, and I think this is in many fields, is I don't think you could go to 5 different physical therapists and the treatment would vary.
It would definitely vary, but let's say for thoracic outlet syndrome, you're gonna get this neck stretch of your scalenes, you're gonna get soft tissue work to your neck, you're going to get a mobilization of your first rib and or your clavicle. You're going to get trigger point release and a stretch of your pec minor, shoulders. And you're going to get...
kind of old school? You might get somebody ultrasounding, stim.
Yeah, stim, ice, heat. You're going to get some form of modality for pain relief, and you're going to do a nerve glide. And I wouldn't do any of that for my patients.
At least not
in the
at
first
few sessions.
Yeah.
I don't have anything else to ask, except for I have one thing to say. Why did the thoracic outlet go to therapy?
All right, hold on. Why did that?
It's so easy, guys.
I mean, I want to say because it wanted to be released, because it had tunnel vision, because
it couldn't handle all the pressure.
Oh, I was trying to think of something with hand.
Nice.
Handle, nice.
There you go. End on a dad joke. So that's our podcast for this week. Hopefully you learned something about thoracic outlet syndrome. Hopefully we gave you some guidance. If you have more questions, you can reach out to us on this platform, on YouTube, on TikTok, at least for the next few days, Instagram, Facebook. Where else are we? We have other, and our website, thespinaltruth.com. Next week, we don't know what we're doing, but we'll definitely have a podcast. So if you have questions, reach out. Hopefully we provided you with some information and guidance. See you next week.